Welcome to today's Council on Black Health webinar entitled When You Know Better, You Do Better, Diabetes Self-Management Among African American Middle-Aged and Older Adults. Today's presentation is part of the 2021 webinar series offered by the Council's Solutions to Diabetes in Black Americans Core. This core is part of the NIH-funded Center for Diabetes Translation Research at the Washington University in St. Louis. The Solutions to Diabetes in Black Americans Core provides methodological and content expertise to advance the field of diabetes research in Black Americans. We appreciate you joining us this afternoon. My name is Tiffany Eaton. I am a doctoral candidate and graduate research fellow at the Dornsife School of Public Health at Drexel University, where the council is based. Currently working with Dr. Shariki Kumanyika, the founding chair of the council. I will be your moderator today. The council's mission is to develop and promote solutions that achieve healthy Black communities. We leverage the credibility and perspectives of Black American researchers, other collaborators, and research partners to facilitate relevant, community-engaged, actionable solutions that positively impact Black communities. Today's webinar will highlight the successes and challenges of a program of research dedicated to the self-management of diabetes among African Americans, including recruitment and retention, as well as discuss next steps in practice and research. During the presentation, we ask that you post questions using the Q&A button in the Zoom webinar interface. We will review and select the questions for our presenter to respond to during the Q&A portion. If your question was not selected for response, we will share follow-up feedback after today's session. Please feel free to also use the chat window to interact with fellow attendees. Today's presentation will be recorded and archived for future viewing. We will publish the webinar online and share the link via email. Our presenter this afternoon is Dr. Dana Carthron. Dr. Carthron is an assistant professor in nursing in the Department of Nursing at North Carolina Central University and a board-certified adult gero nurse practitioner. She has completed fellowships at University of North Carolina Chapel Hill Center for Health Equity Research, Duke University through the John A. Hartford Foundation, and most recently, through the Research Implementation Science for Health Equity program funded by NHLBI. An Army veteran and native of Flint, Michigan, she is devoted to promoting self-management practices among African Americans. Dr. Carthron, I now invite you to proceed.
Thank you so much for allowing me to present to you today. So the quick outline of this talk, I'm going to do a brief overview of diabetes among African American middle and older adults. I'm going to present 3 studies that I've completed in the past. We'll do a full discussion of the studies with the research and practice implications, and then we'll take questions at the end. So it is well known that African Americans disproportionately suffer from diabetes and diabetes-related complications. 13% of all African Americans over 18 have been diagnosed with diabetes, with countless more undiagnosed. And according to CMS, 25% of all African Americans 65 and older have diabetes. And diabetes is a risk factor for CVD, along with other risk factors, obesity, hypertension, and hyperlipidemia. But we also have to think about other factors, such as race-related factors, exposures to stressors such as discrimination and structural inequalities. However, we also know that self-management of diabetes lowers A1C levels, it slows the progression of diabetes-related complications, and improves overall quality of life. But somewhere there's a disconnect, because we have all this information and we've had it for a long time. We know there are barriers to diabetes control. And often you hear from the clinician's viewpoint that the individual is non-compliant. From the researcher's perspective, we are told for so long that African Americans are difficult to recruit and retain in research studies, and therefore we're unable to examine the full scope of the problem. But what is the individual's viewpoint regarding barriers to diabetes control? We have interventions that work in the moment, but are often not sustainable. So what are we missing? So the first study I want to discuss is the trajectory of self-management activities among diabetic African American caregiving grandmothers. I started this journey after conducting a small study that examined the lived experience of these grandmothers raising their grandchildren. And what I found just with that small study is that many of the women discussed having diabetes or they had testing supplies out in the open. So I eventually asked the question, how do you manage your diabetes while raising your grandchildren? And the answer was most always, I don't. So the aims of the study, the first one was to explore the trajectory of self-management activities among these diabetic grandmothers. And the second was to determine what the facilitators and the barriers were to the performance of diabetes self-management activities in this population. This was a longitudinal mixed method study, which combined phenomenology, surveys, and case studies. Of course, I recruited from a lot of known places that were, we found to be very successful, such as churches, daycares, hair salons, and we actually had in the area a local grandparent center. And I interviewed these women 5 times over 18 months. And they were semi-structured interviews where they could add to anything they wanted to talk about. We recorded them, and they lasted between 45 and 90 minutes. And of course, they were African-American primary caregiving grandmothers. They were to be, for this one, 50 to 75 years of age, type 2 diabetes, reside in North Carolina, and English speaking. To analyze the data, qualitatively, the data collection, coding, and analysis occurred simultaneously. We divined all the codes in a code book. We had a team to review the decisions and resolve any differences. We organized everything in a matrix so that we could really dive into the data, and we identified technical and adaptive challenges. For the quantitative data, because the sample was rather small, we just examined trends in self-management variables. We did summary scores for the 6 self-management activities, and we entered them into a matrix. And then we graphed the individual subjects' mean scores at each time point, creating trajectory lines of self-management activities. I had a total of 6 women, and they both were urban and rural. The average age was 61.5, and the average amount of grandchildren that they were raising were 3. Now, for the quantitative findings, this was really, really interesting. We found clusters of times where their self-management activities decreased. Now, in December and January, there were 3 women whose self-management activities decreased. And this was due because December, January is Christmas time. So they spent their money on Christmas gifts, making sure everyone was happy, including family members. So their self-management activities decreased around that time. April to June, during that time, I had women who were paying for prom outfits, things like that, and also graduation activities. August through October, all of them had decreases. And of course, this is a time when school is starting, so they're paying for school clothes, they're paying for extracurricular activities and things of that nature. And again, excuse me, you can see the different clusters in the months, but all of them had decreases in self-management from August to October. For the qualitative findings, there were 5 overarching themes. The first was keeping it at bay. All participants discussed self-managing their diabetes just enough to function or to keep their diabetes at bay or in check. This participant stated, if I explore it, I have to do something about it. So as long as it's stored away and I'm functioning, I don't have to do anything about it. That's reality for me. If it gets bad, I do something. I have these babies and I do what works for me. The next was time constraints. Many of the participants felt that they did not have enough time to prepare meals, especially healthy meals, because of the grandchildren activities or their own activities outside of the home. And this basically made them eat fast food instead of anything healthy. The other thing they didn't have time for was checking their feet. They said it just was not a priority. And they said they checked their feet occasionally, but not daily as recommended or even weekly. And it was very interesting in that some of the ones who discussed checking their feet, they did so improperly, meaning they would manage any issues with their feet by removing calluses with nail files or razor blades. And I asked them, did you ever cut your feet or anything of that nature? And some said, oh, occasionally, but eventually it heals. And all of them reported not seeing a podiatrist well over a year. The next theme was self-diagnosis and treatment. They all managed their diabetes by the way they felt. They used warning signs such as blurred vision, jitteriness, headaches, to diagnose if there was an immediate problem. No, I don't take my insulin every day, but if I start feeling funny or my eyes get blurry, I know what's going on. So I go get my insulin and take a booster. And again, remember, this is someone who's not taking her insulin every day and she's using it as a booster. And a lot of that was because she did not have the money to spend on insulin. So she just kind of stretched it out. And getting to that, finances was a thing that was seen. All participants reported at least one time in the previous 3 months that I saw them, they were unable to purchase strips to check their blood sugar because their grandchildren's needs and also family members' needs took more priority. And we know, of course, that it's not the glucometer that's expensive, it's the strips. And it's interesting, a lot of these women had family members in prison, and because they're considered the matriarch, they felt it was their obligation to send monies to family members in prison. And of course, other caregiving activities, as well as caring for their grandchildren, influenced the types of foods that they were able to purchase. Stressors was another emerging theme. There was a lot of conflict between the grandchild and or the family members. With the grandchild, most of the women's grandchildren in this study were teenagers. So you had the teenage conflict with the grandmother. And then the grandmother had conflict with other family members, often the parents, discussing how they were raising the child. So there was a lot of conflict in that. And all of that influenced their eating patterns. They felt comfort by eating certain foods, such as macaroni and cheese, desserts. And of course, they didn't look at portion sizes. And we do need to do more education in dietary considerations, because one of the participants felt macaroni and cheese was a vegetable. And with stressors, again, all were aware that stress influenced their self-management patterns. So in looking at all this, these trajectories highlight the inconsistency in self-management activity performance because of multiple barriers. The fluctuation in activities increase their risk for diabetes-related complications and directly influence the care that they receive from their provider. And their life context gives rise to challenges that are difficult to resolve and for which providers will not have ready solutions. In addition to that, any self-management regimen that we come up with, we have to make sure that they're embedded in the context of these grandparents' lives. They will not do anything that's going to impede the care of their grandchildren. And we, as providers, we have to be able to listen and watch for clues for challenges that they may be having. The next study I want to talk to you about is called I Can't Fall Apart, Superwoman Schema among Diabetic African-American Caregiving Grandmothers. To give you a little bit of background about Superwoman schema, this is the perceived obligation to self-silence feelings of distress or vulnerability to portray an image of strength for families and communities, and to take on the needs of others while neglecting one's own needs. So the purpose of the study was to explore coping and resilience among African-American caregiving grandmothers with diabetes. And this was a secondary analysis from the trajectory study. We organized the data in a matrix for deep understanding and cross-case analysis for each time point. So we found self-silencing, self-sacrifice, and multi-caregiving. So for self-silencing, that is suppressing feelings of anger, hurt, and regret. It's refusing to tell family members of health needs and delays in obtaining care. Self-silencing was also noted among all participants with breaking of necessary provider appointments. Some of these women hadn't seen a provider in, one was well over a year and a half, but the provider continued to give her refills on her medication. They neglected blood glucose checks and omitted or stretched their medication. Again, just thinking about the booster of insulin, or in some cases metformin. One individual took a metformin once every 3 to 4 days. And all of these women had multi-caregiving responsibilities, which impacted their ability to take care of themselves. And they provided physical and emotional caregiving, financial caregiving, community caregiving, and spiritual caregiving. So to give you a little bit of quotes regarding this, self-silencing, one participant said, "I don't fall apart in front of him," which was her son, disabled son she was taking care of. "And I don't fall apart in front of her. And I very seldom show emotions in front of them. I think that's why I don't focus on my illnesses." Regarding self-sacrifice, with my finances being stretched, I haven't had the copay for the doctor. I can't make the appointment. And for this particular participant, her copay was $3, but she felt that that money was better served for something else other than going to see the doctor. And multi-caregiving, I have to take care of everybody. Sometimes at the end of the day, I'm just too tired to do anything for me. Check my blood sugar, whatever. I'm just too exhausted. So in looking at all of this, we know that Superwoman schema, it served as an asset, but also a vulnerability. The participants felt that they just had to deal with it. Just had to deal with it. And the intersection of stress, strength, and emotional suppression in these grandmothers impacted their ability to self-manage their diabetes. So this moved me a little bit further to kind of look at self-management of diabetes in Black men. So this was the Flint Man Up study, and that stands for Men Are Now United program. And I'm originally from Flint, Michigan, and I moved back up there for a little while because the population of Flint has had quite a few challenges, which I'm sure a lot of you are aware of. They've had a economic challenge for a very long time. Then, of course, you had the water crisis, and so that was all going on during this study as well. And of course, later on, the pandemic. So we decided to start out with focus groups. And we conducted 4 community-based focus groups with Black men to examine initially their lived experience with diabetes and diabetes management. All were from the city of Flint. We had 17 across 3 groups. And with data analysis, we immersed ourselves in the data, and it was constant comparison. And we defined codes in a code book, established categories, and we extracted some themes. The first overarching theme was manning up. And we found this throughout all the participants. They all felt that they had to man up to life, man up with their health. They had to take care of everyone, and there was no time to break down. One participant said, our forefathers did. They man up because if they went to the hospital or to the doctors, some of them didn't come back, and it scared the rest of us, you know? Another participant stated, it just wasn't my thing. I'm from down south. Running to the doctor was the last thing that we done. And this was really interesting. This gentleman said, and it doesn't matter your degree of education, because I had a friend that passed in November and he was an attorney and he passed. And I'm not going to say his name, but he passed from diabetes and we didn't even know he had it. The next theme was Black masculinity. They felt as Black men, they had to be strong. And they felt that as Black men, they were, interestingly, stronger than any other ethnicity out there. But these gentlemen said, and also Black men, we don't know how to be sick, you know, because we always thought we could work it out. Another gentleman, and the average Black man, his first sickness is his last because we don't go see the doctor, all right? Another thing which was really interesting was the peer support for life issues and diabetes. Although we were there to discuss, you know, how they were managing their diabetes and self-management, a lot of the talk was about wanting support for life itself. I don't know, man. It's hard, but you get there. Once you learn the do's and don'ts of diabetes, you know. And that was just some encouragement for one participant to the others, that peer support. But needing support for life issues included. Now I know why this sex thing ain't working right. I thought it was just me before. These gentlemen were discussing the impact of diabetes meds on their sexual functioning. And they all thought it was just them, and so they never talked about it. But being in the group provided a level of social support for them where they felt it was okay to talk about. And the last quote was, you got some good, you got some more information on when the next meeting is. They wanted to continue to meet. And we'll talk a little bit more about that soon. So once we did the focus groups, we decided to get our community-based diabetes intervention moving. And this was a pilot study that we, of course, conducted in Flint. And our question was, can a community-based lifestyle intervention improve glycemic control in Black men with diabetes? And of our inclusion criteria, they had to be Black or African-American, over the age of 18, an A1C of over 8, and have diabetes for at least 6 months. The way we screen for A1C over 8, we did point of care data collection, or screening rather. So when I went to barbershops, clinics, churches, things of that nature, I brought my A1C machine with me and did A1Cs on the spot. And so I believe that, you know, even the ones who did not participate in the study or weren't interested, they at least had that information about where they were as far as their A1C. And we grounded the study in diabetes empowerment and also John Henryism. And we looked at John Henryism because of all the the strength and the masculinity pieces that they were talking about in the focus groups. And John Henryism is high effect active coping and the relentless pursuit of personal goals in the face of adversity. And this is based on John Henry, who was a steel driving man that, worked himself to death. So the overview of the study, we implemented a targeted diabetes self-management intervention. We employed education, social support, and mobile health to improve their glycemic control. We actually were able to conduct or collect real-time data from these individuals. We provided them glucometers that were able to connect to our system. So when they when they checked their blood sugar, it came to us. So we were able to see right away if they checked their blood sugar and what their blood sugar was running. And for analysis, we did single subject repeated measures. Well, that was the design, excuse me. We checked their A1C 3 times at enrollment, at the end of the 2-month intervention, and then 3 months post-intervention. And this is a picture of our study team. The PI was Dr. Woody Neighbors. He is in the back and to the left. And we also had an exercise physiologist who is in the back to the right. And so these gentlemen participated in physical activity while, well, at the end of each session, and he led those sessions, and he is actually also diabetic. So this is a picture of our study participants and the research team. We had 40 participants and the average age was 61.3. Great bunch of guys. So our group meetings, we started off with 2 sessions of diabetes education and empowerment. During this, we discussed what diabetes is. We discussed what it does to the body, how it impacts African Americans. We discussed how to read labels, all of the things that are important for diabetes education. And what we did, we brought in a certified diabetes educator, and we also had a nutritionist to ensure that they got everything they needed. Because a lot of times as we'll send our patients to receive diabetes education and they'll go to a nutritionist, but they don't always truly understand what all of that means. So after each session, we had a question and answer period, and we also had little mini quizzes to make sure that they understood what all of that information meant. Then we had an introduction to John Henryism, discussing what it means to be strong, how that can be an asset, but also a vulnerability. And then the next session was John Henryism and how that could possibly impact your diabetes. The next session was family and social support. That was a very interesting session where they had a lot of discussion about, while they appreciated their spouses, other family members, encouraging them about diabetes, and making taking care of themselves and engaging in self-management activities, often they felt like the individuals were nagging them. And so they felt like the family needed to find a balance as to how often to remind them to where it doesn't come off as nagging. A couple of the men said after a while, the nagging just made them shut down and they didn't listen to anything at all. So that was important. And then they talked about the social support of just being in the group. Just being in the group, they felt was a source of support for them. We then moved into race, racism, and health. This was a very spirited conversation, if you will. We eventually got to health, but there was a lot of conversation about race racism, structural, institutional, personal, perceived racism. That was actually a very long session. The next one was Black racial identity in health. And then the final one was the introduction to mobile health technology. And that was a little bit more, we started giving them text messages each week. And excuse me, actually they were daily. So we did them every day, Monday through Friday, post group session. And there were things on, how to take care of your diabetes, such as, make sure you don't eat fried foods today. Make sure you get, fruits and vegetables. Don't forget to check your blood sugar. Have you checked your feet today? But we also added things about breathing, how to deal with stress. So a lot of stress management issues that we tried to tackle as well through mobile technology. So right now with Man Up, we are currently analyzing the data, analyzing a lot more. Of course, the mobile health data hasn't been analyzed yet. We're completing detailed analysis on John Henryism active coping and their A1C levels. We are seeing trends of increased self-management. We are seeing those trends, and we're seeing trends of decreased A1C 3 months post-intervention. What was really exciting is that we retained 39 of the 40 men in the study. That in excess itself is a huge success. We often hear that Black men are a hard to reach population, or it's hard to keep them in studies. And I think for this particular group, I found that it was all about personal connection. I am an Army vet, so once I told them a little bit about myself, we found out that several members of this particular group were former members of the military, so I was able to connect with them that way. And then I was always also connected to them via sports. So we actually, informally, before we started the sessions, we would all kind of get together and talk about what was going on as far as the Detroit Lions, what was going on in hockey, because we had a few hockey fans, Michigan State, all those great sports teams. So we were able to kind of talk about that. And also the connection was made because we were being sincere. We weren't trying to fake or be polite. I think it was very important to them to feel truly important. So I had a great time giving them my background, and so that it got to where the group became really, really close, and not just the participants, but the research staff as well. So what's on the horizon right now? Currently, I am working to develop Man Up North Carolina. I'm currently in Durham, so I'm looking to start this in Rocky Mount and Edgecombe counties and Nash County in North Carolina. So we're trying to get it started here. I want to also look at how the intervention held up with COVID. Were these gentlemen able to continue their successes with COVID? Because again, you have to remember, they have an economic challenge. They have the environmental crisis, which there are still challenges with the water in Flint. And then the pandemic came, so it was almost one thing after another. So I want to find out, did the intervention hold up after, or during and after COVID, but also just find out how they're doing overall with all of this. How are things with them? And I'm also in the works of developing a large scale study where I'm looking at, I'm going to develop an education program and a mobile technology a portion based on Superwoman schema and John Henryism. And I will be targeting Black men and women in 5 counties here in North Carolina. So let's revisit the question that we talked about before. The barriers to diabetes control. Again, we know the clinician's viewpoint, we know the researchers, but the individual's viewpoint depends on the context of their lives. It was interesting because it looks as though life is more important than living. And when I say that, I mean everything that's going on in their life, taking care of people, being strong, making sure not falling apart. Life was more important than staying alive. For the men, it was about manning up, being strong, and then being able to take care of manly duties, masculinity. And for women, it was about making sure that they could continue the multiple caregiving responsibilities that they had. And, they just handle it. Everyone needs me and I can't fall apart. So in looking at the overall research implications, it's interesting to read when they discuss that recruitment and retention of Black men is so difficult because they're a hard to reach population. They're not hard to reach. I just don't believe everyone knows how to reach them. They're not hard to reach at all. And connection is everything. We need more interventions, not just examining or assessing the problem. We know the problem's there. We have assessed to death. We need more evidence-based interventions to address the major barriers from their life context. We need to include the social determinants of health. We need to make sure that we're incorporating something that deals with the coping of racism. And these interventions, we need to have them culturally grounded with Superwoman schema and John Henryism. And those are just 2 examples. But for this group, I really believe that Superwoman schema and John Henryism is where we need to move forward. So practice implications. Unpopular opinion. We are doing it wrong. We are doing it wrong. We need to completely flip how we approach diabetes management. For instance, when we go into the provider's office, they do the reconciliation with medications and the review, but we need to look, are we hurting more than we're helping? When we find out that our patient has multiple caregiving or all these challenges, which you would do with hopefully a psychosocial assessment, we need to look at this with medications that they're taking. For instance, Actose has a side effect of fatigue. If I'm a grandmother raising my grandchildren, I'm not going to take a medication that's going to make me even more fatigued than I already am. And we need to make sure that we do psychosocial assessments more frequently, because a lot of times they're doing assessments when they first come in as a new patient. They may do one yearly, if they're lucky. These need to be completed every time they come into clinic, because reality and life changes. So again, we need to ensure that we are examining the social determinants of health, and we need to look at how they're coping. It also takes a village, and we know this. We know that we need medicine, nursing, social work. We need to also know what the community resources out there to be able to refer them to things as clinicians we can't handle. one of the things that I think we need to do a better job of is basically GIS mapping, going out there, finding out exactly what the resources are so that you're able to refer your patients to these resources as needed. We need to think about goal setting based on the individual's definition of success. And we've heard about goal setting from the patient's perspective, but we need to do a better job of that. Of course, it needs to be one goal at a time. For instance, if they check their blood sugar once a week and they weren't checking it at all, that's a win. And we need to let them know that's a win. We need to encourage them that, you know, when you're able to, let's start increasing the time, you know, the amount of times that you're checking your blood sugar. But if they check it that one time and they haven't been in the past, congratulate them. It's a win. It's a true win. And then we also, again, need to think about if we're encouraging them to move forward in that goals, what do they need to reach that goal? We need to make sure we understand that. I also wanted to just discuss really quickly about resilience and coping. I think a lot of times we look at resilience in the wrong manner. So first of all, surviving. Surviving is continuing to live or exist, especially in spite of danger, of hardship. It's whatever it takes to stay afloat. Resilience is bouncing back, thriving is growing and moving forward. But in thinking about resilience, I think we use resilience interchangeably with thriving. If they're moving forward and growing, that's thriving. But a lot of times people will say, they will call it resilience. And the challenge there is if a person is at baseline, barely surviving, they're barely surviving, they have some type of impact that drops them down below their point of survival. They come back up. Yes, they bounce back. Yes, they have some resilience, but what did they bounce back to? They bounced back to barely making it again. So we've got to help this population thrive. We've got to help them move forward, cope better, and help them thrive in their overall health. And these are just a few acknowledgements. Michigan State Public Health, University of North Carolina, Chapel Hill Center for Health Equity Research, which is led by Giselle Corby Smith, the John A. Harford Foundation, UNC Ethnicity, Culture, and Health Outcomes Program, Dr. Woody Neighbors, who is another mentor of mine, which I am extremely grateful to him, and Drs. Ruth Anderson and Dr. Chip Bailey. And I am truly, truly grateful to you taking the time to listen to my presentation. And are there any questions?
Thank you, Dr. Carthan, for sharing your work. I would now like to invite attendees to post questions in the Q&A interface or to send them in a chat. We do have a few questions already, and some are program specific and some are general. So I'll try to group them as best as I can. But so first, just for the Man Up study, since that was the most recent one you discussed, did you find any similarities or differences for barriers or even facilitators for self-management based on age or family size?
Yes, we did. What's interesting is that the younger that they were, the worse that their self-management patterns were. It was almost as though they had what's the best way to describe it? I don't want to, it's almost as that they had a reality check, if you will, once they got older. Okay, I'm older now. I need to really get my diabetes in check. The younger ones who were around 40 to maybe 55 or so, they still had a lot of challenges with checking their blood sugar. And they did do a little bit better with their self-management, but not as well as the gentlemen who were older.
Okay. And to follow up on that, one attendee asks, in the Men Up program, did level of education make a difference, or was the lack of understanding more due to not having had the instruction in an appropriate context?
Education did not matter at all. We looked at that, and it was a matter of obtaining the right information, providing information that was relevant to them in their life context. But level of education was not a factor at all.
That's interesting. And so about Man Up again, did you find that the men were spontaneously counseling their peers? And if so, did your team encourage that?
We did. We found that quite a bit. And I'm so glad someone brought that up. What was truly exciting was after we completed all of the sessions, there seemed to be a little bit of sadness. They really wanted to continue to meet. So they actually started doing activities on their own. Some of them started, and this is of course before the pandemic, but some of them started meeting at McDonald's in the morning, the gentlemen that didn't work, or the ones that were working, they found ways to meet together and just kind of talk. And few of them now go bowling together, but they bonded, and because they truly needed that support. And I'm not sure if they didn't realize it before, or were just again manning up and you didn't feel like they needed anyone. But after the sessions, they truly bonded, and we encouraged them. We encouraged them to work together to take care of their diabetes, but also being able to deal with everything that's out there in life.
Yeah, and I think that just speaks to, as you said, you had such a high retention rate, and just speaks to that personal connection and the importance of that,
Yes.
for folks to even want to consider or to continue meeting after, post-intervention is great. Okay, so more questions. Okay, so one attendee says, excellent presentation. Wondering, what are your thoughts on how do we start remaking the systems to reflect this new paradigm? So is it changing the approach of clinicians, making more robust community health programs, or changing the approach of researchers and implementation scientists?
I think it's all of it. I actually think we need to do all of that. In looking at implementation science, we've got to get the right evidence-based interventions and test those and make sure that we are able to get the right content out there, so everyone is using what's needed. From a clinician standpoint, it's unfortunate that time is an issue. A lot of times, when we're going into the clinician's office, so that makes it hard, but we've got to work better as clinicians to recognize the challenges of African-American middle and older adults. We've got to take time to look at exactly what they're dealing with.
Right.
I'm hoping I answered that question.
I believe so. And we
Okay.
also have a follow-up. We also have a follow-up sort of along the same lines. One attendee says, great suggestions for addressing the notion that we're doing it wrong. What are suggested settings or strategies for implementing these suggested enhancements? And so is this feasible within the traditional healthcare delivery model? And, if not, how can we sustain successful programs like Man Up, Man Down?
Well, this is definitely was community-based. So in thinking about healthcare delivery, I think that we could possibly encourage social work, some of nursing, to where we can properly educate our patients within the clinic. We do this huge after visit summary with our patients, and all we do is just give them a sheet of paper. We can use some of these suggestions before they leave, having nursing, social work, case management go through these things, go through coping strategies before they leave. And we need to do an assessment of that. Before we even, because you can't do a strategy until you know what's going on. We need to be assessing these patients with, I'm just focused on our African American men and women using John Henryism, using Superwoman schema. Let's have these scales in-house and assess how they're coping, and then we can come up with strategies in the clinic.
Right. And so another question, are there suggested strategies for better incorporating contextual determinants of health as we are assessing social determinants of health?
I think it's one of those where, because one of the things that I started doing is I would start asking, Black women, believe it, just even over the age of 40, well, I know you have children. Are you caring for anyone else? And a lot of times they don't see it as caregiving. So I said, well, are you, taking care of a spouse? Do you visit? What do you do with the church? And so a lot of things come out in just having a good conversation with them. And again, of course, social determinants of health, but I think we need to do a better job of the assessment piece.
And so thinking of the grandmother's study, just a question, did you notice any similarities or differences based on the number of grandchildren that they were caring for, or was it just pretty much, with the 6 participants, everyone felt pretty much the same?
It was across the board. But what was interesting, it wasn't really the numbers of grandchildren. It was, even though they had teenagers, it was more of the age. So, the younger ones, 13 and up, you saw the extracurricular activities, things like that. But when they were about 16, 17, there were a lot of, these grandmothers wanted their grandchildren to have a good life and have a life like everyone else. So a perfect example is one of the grandmothers spent all this money on making sure her granddaughter had a Coach purse. And this is the same woman who didn't have $3 for her copay. Making sure they had the nicest clothes, things like that. So that happened when they were a little bit older. So more of the differences that I saw were split between the ages of the grandchildren, not really the number.
Got it. And so another question about the grandmother study. Would the grandmothers have had time to come to support groups if they were offered, or if not, have other forms of support been explored, like groups on private social media or similar, I guess, platforms?
Yes, I'm actually trying to work on that now. What was suggested by the grandmothers, actually, they wanted to come to some type of support group, but with all of them being in the church, they suggested things like maybe having it right after church service, something like that, or immediately after dropping grandchildren off to school. So that was what they wanted as far as some type of support group. But they did want to talk to other grandmothers and be able to interact. But again, these women, and I had to pull that out because these women really would not talk about what's impacting them. It was about their grandchildren and making sure they were taken care of.
Right. And so, just for a reminder for attendees, if you have any questions, please feel free to post them. I do have one more question. You mentioned it, you alluded to it a little bit when you were talking about the need to improve assessments for the social determinants as well as the contextual determinants, but what are your ideas on ways to increase interactions with the providers? Or have you engaged in provider training as to how to do better?
I have not engaged with providers. Well, let me change that. Formerly, I've done so informally, but no, I have not done that yet. I really am working on developing some type of assessment tools that would complement John Henryism and Superwoman schema, so we can kind of determine, what their responsibilities, what is their life on a daily almost quality of life, but trying to get more of those contextual factors. But that's kind of where I am right now. I'm still trying to develop that piece of it.
That's great. We'll be looking forward to that. I just want to make sure that I'm not missing any questions that were sent in the chat. No, I think we've got all the questions from attendees. And so again, just thank you, Dr. Carthon, for this informative presentation on the successes and challenges of research dedicated to diabetes self-management among African-American middle-aged and older adults. On behalf of the Council on Black Health and the Solutions to Diabetes in Black Americans Core, I would also like to thank our attendees for participating in today's webinar. We will send an evaluation survey for this webinar shortly. And just as a note, stay tuned for our next webinar, which will be on July 28th, in which we will hear from Dr. Lanaki Blackman-Carr, who will present some of her work. Have a wonderful afternoon, everyone. Take care.